Hello, my name is Dr. Robert Townsend, PhD. I'm in Albuquerque, New Mexico, USA. Thank you for being here today. I'm very happy to be here with you. Um, I've been a mental health practitioner since 1975, and I own and operate a private mental health clinic since 1997. I've been doing independent neurobiochemistry research since 2001, and today I'm here to tell you about a new method of treatment for bipolar disorders. This is based on an article that I wrote called Low Dose Risperidone Every 3.8 Hours, or Superior Efficacy in Treatment of Bipolar Disorders. It was published in the Journal of Psychology and Psychotherapy on January 4th, 2022. This is a new method of treatment that can improve the lives of 2.25 billion people. 44 million people have bipolar disorders. When bipolar patients, their affected household members and affected community members are combined, bipolar disorders affect over 2.25 billion people worldwide. Studies from 11 countries found that 32.4% of people with bipolar disorders, that's 14.9 million people, exhibit aggression, verbal aggression, destructive behavior, and or physical violence. People with low adherence to bipolar medications exhibit 3 times more aggression. Studies have also found that 59% of people with bipolar disorders have suicidal ideation. That's 27.14 million people having suicidal ideation. 56% of people with bipolar disorders have at least one suicide attempt. That's 25.76 million people attempted suicide. 19% of people with bipolar disorders die from suicide. That's 8.74 million people have died from suicide. Research found that bipolar treatment fails 86.9% in 1 year from a study in France during 2021. A study in Korea in 2012 found that bipolar treatment fails 87.1% in 3 years. Failure is defined as people who drop out of therapy or medications, or have poor adherence to their therapy and medications. It's essentially an 87% failure rate. It's a very high failure rate. Providers primarily blame their patients for treatment failures. When bias against patients is removed, the high rate of failure is due to over-medication. Patients cannot and should not tolerate over-medication. Published guidelines tell providers to prescribe bipolar medications in amounts that control severe symptoms. This causes patients to be over-medicated because their symptoms are not severe the majority of the time. Bipolar medications and guidelines do not accommodate the waxing and waning of bipolar symptoms. Current bipolar treatments have serious flaws that explain the 87% rate of failure. A major flaw is that bipolar treatment antipsychotics are formulated for administration only once or twice per day. Manufacturers omit the 87% rate of failure when they tell clinicians that once per day medications have the best patient adherence. Manufacturers don't say they want to increase sales of high dosage once per day pills because those are the most financially profitable products. Manufacturers don't mention that once per day pills don't provide ways to manage symptoms exacerbations. I'm here to present a new method for treating bipolar disorders. This is a new paradigm that gives patients concrete tools to control symptom exacerbations. This new paradigm was discovered and developed by a 2007 to 2022 15-year independent research program. The first patient started using this new method 15 years ago. He was a wealthy 45-year-old corporate management medical doctor. He was in several failed bipolar treatments before we met. I told him about this new method and he asked to try it. With this treatment method, he stopped losing $2,000 per week gambling in casinos. He stopped paying for sex at strip bars. He stopped having nightmares. He paid $75,000 in taxes that he owed to the IRS, and he resumed living with his wife. Now, at 60 years old, he still adheres to the medications I'll tell you about, and he attends scheduled therapy sessions. He's not alone. 50% of my patients have bipolar disorders. All of them adhere to the medications and attend scheduled therapy sessions. This new method uses valproic acid ER and risperidone in ways that have not been used before. This new method of treatment starts with just valproic acid ER taken every 12 hours. It is titrated in a way that prevents grogginess, and it becomes adjunctive with risperidone. Valproic acid is a more effective mood stabilizer than other anti-epileptics. After proper titration, it doesn't sedate patients and slow their cognition like other anti-epileptics. Unlike other anti-epileptics, it increases absorption of risperidone into the bloodstream, thus causing good effects from taking less risperidone. To titrate valproic acid in a non-groggy manner, you want to start with 250 milligrams taken an hour before bedtime, for example 9 p.m. When there's no morning grogginess from that for a week, add 250 milligrams 12 hours later, for example at 9 a.m. When there's no grogginess for a week, add another 250 milligrams an hour before bedtime, and when there's no morning grogginess for a week from that, add another 250 milligrams 12 hours later. The patient is now taking 500 milligrams every 12 hours. The therapeutic blood level for bipolar treatment is 85 to 100 micrograms per milliliter. You want to get as close to 100 as possible. Valproic acid provides temporary symptom relief. But when that relief fades, that's when you want to start titrating risperidone. This new method of treatment uses unique characteristics of risperidone that the manufacturer hides from clinicians and researchers. Risperidone is a 4-hour antipsychotic that is falsely advertised as a 24-hour antipsychotic. 4-hour risperidone can accommodate and treat waxing and waning bipolar symptoms as needed. With 4-hour risperidone, a patient can learn as needed dose adjustments, and a patient can control symptom exacerbations of various severity. Product monographs and guidelines say bipolar treatment antipsychotics such as Zyprexa and others are 24-hour, once-per-day medications. The risperidone monograph and guidelines say that it is a 24-hour, once per day medication. But in truth, risperidone is a 4-hour chemical, and paliperidone, a metabolite of risperidone, is a 24-hour, once per day medication. The product monograph, written by the manufacturer of risperidone, uses deceptive linguistics, claiming risperidone and paliperidone are a single entity under auspices of, quote, active moiety, unquote. The monograph silently omits that in the 1990s, the FDA approved risperidone for bipolar disorders, and the FDA rejected paliperidone for bipolar disorders in 2006, 2009, and 2011. 20 hours of the 24-hour medication that the manufacturer calls risperidone, 20 hours of that 24-hour medication consists of paliperidone. But wait a minute. Paliperidone is not FDA approved for bipolar treatment. The FDA did not approve it. They rejected it 3 times in 2006, 2009, and 2011 for very good reasons. The word risperidone has come to have 2 definitions. It's a misleading name that the manufacturer gave to the 24-hour medication. It's also the scientific name of a 4-hour chemical inside the 24-hour medication. This research study found a way to separate the neural actions of 4-hour chemical risperidone from its 24-hour metabolite paliperidone. This research discovered a way to activate the therapeutic properties of risperidone without activating paliperidone. Thus, the name of this treatment method is differential activation. For this new method of treatment, low doses of chemical risperidone were calculated to be therapeutic amounts that didn't cause over-medication. Chemical risperidone was administered every 3.8 hours because it has a duration of 4 hours. Doses of chemical risperidone were calculated to metabolize plasma concentrations of paliperidone below the threshold concentration that activates paliperidone. It's necessary to prevent neural activation of paliperidone. Active paliperidone increases serotonin. Serotonin is toxic for bipolar disorders. In the 1993 FDA application and original product monograph, the marketing department for risperidone wrote allusions that the 4-hour and 24-hour chemicals are one entity. They wrote of similar pharmacological activity, combined concentrations, and a chemical structure difference of only one molecule. The authors used these apparent similarities to wrongfully avoid revealing the 2 chemicals' significantly different neural actions. The 1995 definition of risperidone as a twice-per-day medication changed by 2007 to a once-per-day medication. Doses in the risperidone product monographs are always high enough to activate paliperidone. Monograph authors omit that neurally active paliperidone increases serotonin activity that is detrimental to bipolar disorders. Production and release of serotonin transport cells is significantly reduced by risperidone, but not by paliperidone. Risperidone at 1 micromolar unit reduced arachidonic acid AA release by a significant 14 plus or minus 2%. A reduction from 3 times more paliperidone at 3 micromolar units was insignificant, of 0.5 plus or minus 8%. There's a 3-to-1 neuroactivation ratio between paliperidone and risperidone. Additionally, they have two very dissimilar neural actions. Paliperidone, shown in red, increases serotonin activity by increasing the binding sensitivity of serotonin transport cells, arachidonic acid. This increases the amount of serotonin that is transported to receptors. This increases receptors' exposure to serotonin. This increases the amount of serotonin that is absorbed by receptors. Risperidone, shown in blue, inhibits receptor sensitivity and absorption of serotonin by decreasing the production and functions of serotonin transporter cells, arachidonic acid. Paliperidone plasma concentrations of less than 25 micrograms per liter are ineffective. They show no change, no improvement in patient scores on the Clinical Global Impression Rating Scale. This establishes a paliperidone activation threshold of 25 micrograms per liter. A paliperidone serum concentration of 25 micrograms per liter is metabolized by risperidone dose amounts of 0.051 milligrams per kilogram per day. In order to prevent activation of paliperidone, 0.050 milligrams per kilogram is the maximum risperidone dose amount per day. The efficacy threshold blood level of risperidone was found through a series of calculations, and the efficacy threshold of risperidone is 6.5 micrograms per liter. Patients and household members of my clinic reported efficacy onset of risperidone at 15 to 20 minutes after dose intake. I observed the efficacy onset at 15 to 20 minutes after dose intake. Patients and household members reported efficacy fading starts at 3 hours and 55 minutes after intake. I observed the efficacy fade starting at 3 hours and 55 minutes. Previous research showed the duration of the chemical structure of risperidone is 4 hours and 10 to 20 minutes. Therapeutic differential activation doses are taken at 3 hours and 50 minutes, which is 10 minutes before the hour 4 efficacy termination of a previous dose. A 15 to 20 minute dose onset of increasing plasma concentrations combines with 15 to 20 minute decreasing concentration of a terminating previous dose. The additive combining of dose 1 termination and dose 2 onset concentrations sustains an efficacy sufficient concentration across sequential doses during transitions from dose 1 to dose 2. Differential activation method of bipolar disorder treatment uses small dose amounts of risperidone taken in 5 times per day every 3.8 hours. That's 3 hours and 50 minutes. Doses maintain the efficacy threshold of risperidone at 6.5 micrograms per liter plasma concentration. small dose amounts prevent paliperidone neural activation. The amounts of risperidone that are beneficial vary according to patient's weight, and several weights are listed here. To identify a patient's appropriate range of dose amounts, being highest and lowest that's likely to benefit a given weight. You can go to dose per body weight calculators, such as the omnicalculator.com that I used for this research. In the calculator, you enter the patient's body weight and enter the 0.5 milligrams per kilogram that is under the amount for activating paliperidone. The calculator will tell you the patient's maximum volume of 4-hour risperidone per day. You can use a standard calculator to divide that volume by 5. This will tell you the patient's maximum amount per dose for 5 doses per day. In order to find a patient's lowest therapeutic dose amount in his or her range, divide the amount of each 5 doses, divide that by 3.6795. This tells you the dose amount that activates risperidone per dose. In the differential activation method of bipolar disorder treatment, patients can learn to control acute exacerbations. Patients are helped to identify the onset signs of exacerbations so that they can start controlling exacerbations before they're severe. When a patient identifies onset signs, or we call them red flags, he or she is actively guided and encouraged by the therapist to calm the onset right away with extra dose of risperidone at 0.25 milligrams. That's the lowest dose that is produced. For most exacerbations, adding one extra 0.25 milligram tablet is sufficient. The patient can take an extra, the 0.25 milligrams with a routine dose amount every 3 hours until the exacerbation ends. Then the patient can return to taking the routine dose amount every 3.8 hours. This allows the patient to increase their medications temporarily to control exacerbations and return to the normal dose and not become over-medicated. For severe exacerbations, if one extra 0.25 milligram dose is not enough, after 30 minutes, the patient can add another 0.25 milligrams. If that's not enough, after 30 minutes, the patient can add another extra 0.25 milligrams. The patient can add an extra 0.25 milligrams every 30 minutes until the exacerbation is stabilized. Patients should talk to the therapist as soon as possible and take the stabilization amount of extras with the routine dose amount every 3.8 hours until the exacerbation recedes and doesn't return. The patient can gradually reduce the number of extra pills according to their sense of stability. Then they return to taking just the routine dose amount every 3.8 hours. It's very different than the monographs that recommend clinicians prescribe this risperidone in amounts that control severe symptoms all the time. That recommendation causes patients to be over-medicated. This method that uses 0.25 milligram extra doses as needed, this does not cause over-medication. It is quite difficult for a provider to calculate the sequence of 7 equations that identify the patient's range of therapeutic dose amounts. It's faster and much easier to use the table of dose ranges in my science article. The article and the table are available online free of charge. Some examples of risperidone dose range sizes are 0.44 milligrams, difference between high and low, 0.51 milligrams difference, 0.55 milligrams, 0.65 milligrams, and 0.73 milligrams. Back that up. Within a minimum to maximum dose range, there's a severity optimal dose amount. The low to high dose variances provide plenty of latitude for routinely accommodating each individual's baseline of illness severity. Risperidone is available in pills of 0.25 milligrams, 0.5 milligrams, and 1 milligram. Most bipolar patients do well by starting with 0.25 milligram pills. The typical long-term regimen is 0.5 milligram pills every 3.8 hours. Routine dose amounts need to accommodate body weight and illness severity. My most severe bipolar patient weighs 210 pounds, and her optimal doses are 0.75 milligrams on a routine basis every 3.8 hours. Another patient who weighs 350 pounds has an optimal dose of 0.5 milligrams. So determining the optimal dose to use routinely depends on body weight, but moreover, it depends on response according to the severity of the person's disorder. Again, this information is written into a research article that was published in the Journal of Psychology and Psychotherapy on January 4th, 2022. This is a 15-page article. I'm scheduled to present this information about bipolar treatment and information on a new way of treating Parkinson's disorders with methylphenidate. I'm scheduled to present both of those topics at 7 neuroscience conferences and health conferences between now and May of 2024. For the benefit of your bipolar disorder patients and their families, and for their better futures, I sincerely encourage you to read, study, and implement the method of bipolar disorder treatment that I presented to you today. This method is assuredly and beyond all doubt medical history's best, most effective, and safest treatment for bipolar disorders. I've observed this for 15 years, and my patients say this to me for 15 years. The research and treatment method I presented today are available online for free. Enter a search phrase that is provided below. The search phrase contains my name and the title of the article I presented. It's Robert W. Townsend, and the name of the article is Low Dose Risperidone Every 3.8 Hours superior efficacy in treatment of bipolar disorders. I'm going to leave this information on your screen for a couple of minutes so that you can write it down. Thank you. Thank you very much for being here. And thank you for listening.